Canada has a healthcare crisis. On average, Canadians are waiting 31 weeks to see a specialist, 16 weeks for an MRI scan, and upwards of 22 hours in the emergency department if they need a bed in the hospital.
One of the reasons why we find ourselves in long lines, long waits, and shortage of family doctors, for example, shortage of capacity in emergency departments, surgeries, and so on, is because it hasn't been planned well. I'm Opher Baron. I'm a distinguished professor of operations management at the Rotman School of Management, University of Toronto. I'm also the CEO of SimilQ.
Opher specializes in supply chains, looking specifically at chains that are filled with randomness. Over the years, he's worked with a number of hospitals to better understand how they can better manage and plan across the unique randomness of a healthcare setting. He's an interesting person to chat with when it comes to dealing with our current healthcare crisis. In media and policy discussions, the loudest solutions are often more. Hire more nurses, train more doctors, buy more MRI and X-ray machines, build more beds. But as Opher says, we didn't get into this crisis overnight, and hiring more, building more, buying more all takes time. There are, however, changes we can make today that can have an impact. The question becomes then, are we equipped to make them? Welcome to the Executive Summary. I'm Megan Haynes, editor of the Rotman Insights Hub. I want to start this episode recognizing that the issues facing Canadian healthcare are complex, nuanced, and not easily addressed. There are, among other problems, serious divides between things like city versus rural care and systemic issues accessing healthcare for marginalized groups. There are shortages of beds in long-term care homes, not to mention a lack of funding for things like preventative care and mental health initiatives. However, we only have 15 minutes, so we're going to home in on the specific issue of resource management. In Canada's medical system, we have what Opher calls a supply shortage. In very simplistic terms, if you think of patients as the demand, we go to hospitals and doctors' offices with ailments. You can think of the medical professionals, the doctors, the nurses, the radiologists, and the devices, those MRI machines, beds, etc., as the supply. We simply don't have enough supply to deal with an aging and growing population. One study estimates that by 2030, we'll be short about 44,000 physicians, and primary care doctors are in the shortest supply. Today, roughly 6 million Canadians are without a primary care physician.
Can't listen to the news today without hearing on shortage of family physicians in Ontario, in Canada in general, in the world more broadly.
This has a really big impact on all elements of our healthcare system, but perhaps most acutely on hospital emergency rooms. The Canadian Institute for Health Information estimates that 1 in 7 visits to an ER could have been managed by a primary care provider. Politicians, hospitals, nursing unions, and medical associations have been calling for strategies to reduce these gaps. Ontario launched 2 new medical schools with the goal of graduating at least 500 more doctors a year. Provinces have also made headway in reducing provincial barriers to practice and work, and a concerted campaign has taken place abroad with the hopes of attracting international talent. But what if it's not enough?
We need to start planning our workforce ahead much better, right? The shortage in nurses leads to lots of burnouts. COVID kind of highlighted this in a tremendous fashion. So those are things that are, some of them putting money into it is helpful, but we need something bigger than that. We need to be able to use our data more effectively. We need to plan our capacity more effectively.
After all, nursing takes 2 to 4 years of schooling and training. Medical schools take 4 years, followed by 3 to 7 years as a resident. That means those first graduates of the new Ontario programs won't be working for nearly a decade. So how did we get to this state? Opher doesn't mince words.
One of the reasons why we find ourselves in long lines, long waits, and shortage of family doctors, for example, shortage of capacity in emergency departments, surgeries, and so on, is because it hasn't been planned well. When our leadership is here for 3 or 4 years, they're very myopic about this. Decisions that are 15 years down the road, investment in this is hard to convince the current regime to do because they're going to pay for it. The results someone else is going to see. And I need to be elected in a couple of years again, so I cannot waste money and time and effort on those non-myopic things.
So let's be real here. Investing in new talent in particular is a great place to start, and it is incredibly important. But it is a long-term solution that probably needed to be tackled years ago. That doesn't mean that hospitals and governments are completely without the tools to make wait times, particularly at emergency rooms, more efficient today. Hospitals broadly, but emergency rooms specifically, are really chaotic places. We don't necessarily mean that these are places without order and reason. We mean it more from the perspective that these are places besieged by unpredictability.
So let's think about emergency departments. You go to emergency department when you need to see a doctor. It's not always a life or death emergency, right? If somebody breaks a leg or that, you go there as well, right? You have a minor car accident, you want to make sure everything is okay. You also go to emergency department. If I'm the head of the emergency room, I have uncertainties in how many patients would arrive during each hour during the day. I have uncertainty in what is going to be the characteristics of different patients in terms of their acuity level, in terms of their ages, their comorbidities, how they arrive, walking or through ambulance. On the other hand, I also have some uncertainty in the supply, so in my resources. So beds and MRI machines are there, but a doctor got stuck on the road with a flat tire. They show up an hour and a half later. A nurse had an issue. He doesn't show today. So if you think about all of this randomness, all of this uncertainty, it creates mismatches between the capabilities that we have and the needs that we have.
Not only are hospitals chaotic places where sometimes the supply, the medical professionals, isn't set up to meet the patient demand, but emergency departments and healthcare broadly struggle with other challenges. The main supply is people, and people aren't uniform widgets. They come with their own habits, perceptions, motivations, and goals. Take the issue of incentives and continuity of care. Traditionally, if you go to an emergency room, there's an expectation that the doctor who sees you at the start of your visit will be the doctor who sticks with you until you're discharged. That's called continuity of care. However, in Opher's research, they found that this sometimes leads to an interesting phenomenon. Doctors in the emergency room would see lots of patients at the beginning of their shift. But as the shift went on, they become less likely to pick up new patients, especially as they inch towards the end of their shift.
We're two doctors, we're taking care of a patient, and my shift ended. I did the first assessment. You have to do the second assessment because I go home. First of all, we don't like it because of continuity of care. I mean, I know these patients, I know what I had in mind when I ordered this diagnostic and this test, and you can read it, if you can read my handwriting, which is terrible because I'm a doctor after all. This issue of continuity of care is important. So doctors don't like to move the treatment of a patient in the middle from one doctor to the other one.
If you're expected to see a patient through to discharge, it becomes more challenging to pick up new patients when your shift is almost over. This becomes compounded by the other challenge, payment. Different hospitals pay their staff differently, but generally doctors in Canada are paid a fee-for-service model. That means while some doctors receive a salary, they are often paid based on how many patients they treat. According to the Canadian Medical Association, more than 95% of doctors in Canada receive at least part of their compensation through this model. If you're not there to see a patient through to the end of treatment, you may have to split the payment with another doctor who takes over your caseload. And as a result, there might be less financial incentive to pick up that patient you know you can't see through to the end. That isn't to say doctors only see patients at the beginning of their shift or won't hand off a patient because doing so means they won't get paid. But what Opher's research shows is that lots of emergency rooms have a system that disincentivizes doctors from taking a consistent patient load throughout their shift, instead encouraging to front load their patient roster. As a patient, that means
if I arrived at the beginning of the shift, I can be lucky in terms of the fact that I'm being seen quickly. If I arrived at the end of the shift, I'm kind of being unlucky because I need to wait till the beginning of the next shift, essentially. So this creates additional variability in the waiting time. The waiting time is not flat anymore.
So can hospitals address this issue?
they can start thinking about how to change their internal incentives or how to change their behavior in order to reduce the impact of the shift effect and how it changes their ability to meet KPIs.
How could the hospital shift their pay structure to be an incentivizer? Or can they create a system where the decision is pulled from the doctor's hands completely? These are big changes, but they can't be done until we tackle the next challenge, data collection.
There's a lot of data collected generally in healthcare as well. It is not always the right one to support operational planning. So much of the data that is being collected today is being motivated by financial incentives and accountability.
In Ontario, for example, part of a hospital scorecard includes things like how long you waited in an ER before being assessed, how quickly you were offloaded from an ambulance, and how many people left the ER without being seen at all. This isn't wrong per se, but for operation management practitioners, it's just not enough information.
What you are measuring is, say, ambulance offload time, which is one of the important KPIs in the emergency department. You know when the ambulance arrived, and you know when the patient went from ambulance to, say, the triage. But you don't know when the nurse started taking care of these ambulance patients in order to kind of move them to triage.
If you don't have this timestamp, you don't know how much time your resources, the nurses, spent on this activity.
From the data, this is something that is missing.
So what can we do about it? Well, first, let's recognize that doctors and healthcare administrators aren't operation management professionals.
Every time I have a doctor in my MBA classes, and he's starting to talk about queuing theory and waiting time, you can see their eyes open. Yeah, this is important. I want to understand what's going on here, right? Unfortunately, not many doctors are going through such training.
Better, more robust data collection, which don't necessarily align with provincial metrics, is important as well. Because we need to understand if our incentive models, our scheduling structure, our flow is working correctly, policymakers and hospitals need the right information to make sure they can better plan for the future. They don't have to tackle these challenges alone, and many researchers and academics like Opher are working with hospitals now on figuring out some of these optimization challenges. He's done work with several across Ontario, including a recent partnership with Erie Shores, which was struggling to optimize patient flow in its emergency department. Erie Shores wanted to know if there was a better way to assess, process, and help people who, say, break a bone, but don't necessarily need to stay in the hospital. Historically, planning for resources around these non-acute needs is based on the previous year's data. Again, very simplistically, if 10 people broke their leg in 2023, then you might expect 12 people to break their leg in 2024. But what happens if skateboarding becomes super popular and suddenly 20 people have broken their leg in 1 year? How do you staff for and change your ER plans on the fly?
When you have to choose different interventions, different actions, and evaluate what is their impact on performance, you want to have an evaluation of which project is better to choose between project 1 and project 2. In the context of managing waiting times, thinking about the emergency department, elective surgeries, MRI waits, right? All of these wonderful things that we hear about, and when we experience the waits are really long. The way to get an evaluation of what is the impact of different interventions, I would say, requires simulation.
This is where AI comes in, and it's an area Opher is particularly excited about. In July 2024, he and his colleagues launched SimulQ, an AI simulator. It is essentially a digital version of a hospital setting. In these digital simulations, admins can pull a lever on a change they want to make, say testing a new scheduling system, to simulate what would happen in the broader environment. What knock-on effects could it have? Would it actually save the hospital money? Would it help patients get seen faster, or might there be issues down the pipeline?
Oh, it's a snowy day. My digital twin knows exactly how many people are on the floor, knows exactly how many nurses and doctors are on the floor with their diagnostic, has a good ability to see what would happen in this snowy day where demand is a little bit higher. And then I can decide if I want you to come an hour earlier, 2 hours earlier, what is the benefit in terms of performance to the system.
Now, building and training these AI systems takes time too. So, like training doctors and nurses, AI won't magically solve hospital staffing issues. But it's worth remembering that there are tools we can use while we wait for those thousands of doctors and nurses to make their way through the training and bureaucracy. Because in the end, you can't just throw money at healthcare and hope that fixes the systemic and chronic shortages we've built over decades.
Just like anything else, it's using the money in the right fashion. Adding 25% budget to all hospitals is not necessarily going to solve the problem. You need to invest in the right places. You need to think about it better. And also, as I mentioned, in terms of the strategic planning, we need to start planning our workforce ahead much better, right? I hope that once people understand better what is the important data for them and what they can do with the right data, we'll have better data and we can push and improve the efficiency of our systems better. And given the current resources, investing a little bit more in the right places.
This has been Rotman Executive Summary, a podcast bringing you the latest insights in innovative thinking from Canada's leading business school. Special thanks to Professor Opher Baron. Join us next month as we chat with Professor Minlay Ye on why we need to take a serious look at auditor bias. If you're just tuning in for the first time, check out some of our earlier episodes. We tackle everything from how to deal with burnout to whether AI can really be regulated. Make sure you subscribe on Apple, Spotify, YouTube, or Amazon. And please consider giving this episode and the series a 5-star rating. It's hugely helpful in getting the word out. And if you want more bold ideas in less time, check out Rotman Visiting Experts, a monthly podcast featuring sharp conversations with today's top business thinkers, including Oliver Burkeman, Malcolm Gladwell, and Amy Edmondson. It's available wherever you get your podcasts. This episode was written and produced by Megan Haynes. It was recorded by Dan Mazzata and edited by Avery Moore-Kloss. Thanks for tuning in.